Welcome to Toledo Clinic TV. In this segment, we are joined by two cardiologists, Dr. Nahhas and Dr. Gildeh. Thank you for being with us.
Thank you.
You are one of, or maybe the only, practice in the area that treats these venous disorders with certain procedures. So tell us a little bit about that.
All right. You want to take it first, Dr. Gildeh?
Go ahead. So, I mean, the problem itself is the veins of the legs. That's what we're looking at. People know them colloquially as varicose veins, but it's a much more extensive problem than that, where the veins themselves become problematic over time. Some people are born with these problems, or at least have genetic predispositions. Some people develop them over time because of various risk factors, and they start to notice them with large bulging veins, some swelling of the legs, heavy discomfort in the legs, aching at the end of the day. And it's a very common problem that I think a lot of people can identify with. We see 40+ million people in the United States have this problem in some degree, and only a small proportion of those actually come in for evaluation and really think it's a problem. But it can progress, it can get worse. The symptoms can be quite disabling, and it can lead to various skin changes, ulceration, discoloration of the legs, and even infections that can present as well. So it's definitely an important problem for us to take care of.
Most people probably come to you because they're experiencing some pain or because they don't like the sight of them, but they don't have to live that way. There are treatments, and so would you like to start with talking about some of these procedures?
Sure. I mean, it's frequently underdiagnosed. Just to add to what Dr. Gildeh said, underdiagnosed people sometimes say, don't worry about it, raise your legs and all that, but you don't want to live your life raising your legs only. And people can have anything from swelling to aching to numbness to neuropathy and all that. So treatment options all depends on the anatomy. We do venous scanning, a study called venous insufficiency, look at the anatomy of the veins, and depends on the anatomy, treatment is tailored to that specific anatomy, and that could range from using radiofrequency ablation to close bad veins, or a glue called venous seal, is medical adhesive, or could be Varicose, which is chemical, non-physician compound chemical that ablates the vein by injecting that inside the vein, and it makes the vein collapse and destroys it basically. Could be also microphlebectomy, which is removal of segments of vein that are too large to be treated by other modalities, and sometimes sclerotherapy for some smaller veins like spider veins and the telangiectasia, which are also looking like spider veins, slightly bigger. So these are really 5 treatment modalities, and some patients require more than one treatment for the different problem they have. So we may start treating the long vein first, then go to the branches to give them complete satisfaction and good results.
And as you said, it just depends on the patient's anatomy as to what might work best for them.
Most of the time, people require more than one kind of treatment to get satisfaction, to get good results.
All right, Dr. Gildeh, how do you know when you need to actually come in and see you or another cardiologist to get the problem fixed?
Well, a lot of people don't know, and that's part of what we do as cardiologists. We evaluate the whole patient. So we start with a comprehensive cardiac examination, and sometimes we pick it up on people that haven't really thought much of it. Things that people experience at home, though, is that kind of heaviness in the legs, that aching, that swelling, that usually end of the day symptoms that worsen as you're on your feet. And then sometimes, especially if it progresses to things like ulceration or skin changes, then we want to see people and have that taken care of before it becomes quite a significant problem. In general, though, as you mentioned, most people see the visual changes, those larger veins, but that's just an external sign of a deeper problem. So part of that venous scan that we do perform looks at the deeper veins, not the true deep veins, but the superficial veins that are deeper, maybe not visible, but they feed those larger veins that can be seen on the surface. So part of the problem is finding those veins and then knowing where the problem lies, treating the deeper ones so that then we see if the knock-on effect is that those other veins are improved or if they need those other modalities that we mentioned that might take care of the whole picture for them.
Last question, are there things that we could be doing when we're younger to prevent problems later that would require these procedures?
Well, obviously, you cannot change your genetics, and so the risk factors for developing venous disease: age, gender, women more than men. As we get older, there's more chance. Trauma, prior history of clotting to the vein, long-standing occupation, teachers, doctors, nurses, people who stand, people work in retail stores, and any profession that requires long standing. there is definitely, I mean, we see people that every member of the family, men and women, have bad veins. If you have that, most likely you're going to have it. Losing weight is definitely a good thing in the long run. That can help. So increasing weight is other risk factors. So we try to work on that in addition to closing the bad vein. And all the treatment we talked about really emphasize either removal of the vein in some occasions or closing the vein. All the modalities from radiofrequency to glue to very thin chemical ablation. We try to close the bad vein, and the blood will circulate back to the heart through healthier veins. And the legs have hundreds of smaller veins connecting to the deep veins. And what Dr. Gildeh said about deep veins, he meant the superficial veins that lay under the skin.
Can't
that
see
we
them.
cannot see it, because that's different from the deep venous system. So we're focusing treatment on the superficial venous system, and most of that is not visible to the naked eye. What is visible is like the tip of the iceberg.
Okay, but patients need to know that there is help. They can do something
Absolutely.
about it.
Mm-hmm.
All right.
I mean, it's very easy. The session takes about half an hour for any of the treatment modalities. Done in the comfort of our office. We don't use sedation. We don't put venous line in the patient. They come walking, leave walking, they drive their car, go back to work, same day. And it's just incredibly comfortable procedure. Some of them fall asleep while we're treating.
Okay, thank you so much for being with us.
Thank you.